Good evening, everyone. Welcome to this weekend's tutorial. And we'll be looking at intravenous anesthetics. A very common topic, but hopefully we'll learn one or two things from today's tutorial. So our learning outcomes, all right, is as given above. We'll define and classify intravenous anesthetic agents. We'll look at the pharmacokinetics and pharmacodynamics of commonly used agents. We'll, at the end, should be able to describe the mechanisms of action of killing agents, and you should be able to discuss the role of IV anesthetics in TIVA and procedural sedation. So that's what we hope to achieve. And our outline is as given on the screen. So by way of introduction, let's remind ourselves that intravenous anesthetic agents are groups of medications that when administered via the parenteral route produce rapid loss of consciousness. All right, so the anesthetic agents that are administered through the parenteral route, they are broadly classified into two barbiturates, which include thiopentone sodium and methohexitone. We have the non-barbiturates, which include the neuroleptics, Midazolam group, the benzodiazepines, phenols, and dissociative ketamine. All right, so what are the ideal properties of, or the properties of an ideal IV anesthetic? Just remember that an ideal anesthetic should be awesome, all right? Awesome, that is the mnemonics. So number one, it should be affordable with analgesic property at sub-anesthetic doses. So one of the ideal property of an IV anesthetic is that it should be affordable and it should have anesthetic property at low or sub-anesthetic doses. It should be water soluble. All right, emergence or excitatory effect should be absent. All right, the S is that it must be stable in solution with long shelf life. Stable in solution with shelf life that is long. It should produce 1 arm brain circulation time, rapidity of onset of action, and it should have no systemic depression. It should have minimal metabolism without histamine release, and emetic and other side effects should be absent. So if you try to remember, use the mnemonic awesome. Affordable with analgesic property. It should be water soluble. Emergence and excitatory effects should be absent. It should be stable in solution with long shelf life. It should produce 1 arm brain circulation time. Metabolism should be limited without histamine release. And emetic and other side effects should be absent. Please mute your mic when you are joining, please. Okay, so classifications. Another way to classify apart from the first one we did, all right, induction classification of IV anesthetics, we can say classify them also as induction agents or sedative or hypnotics and other agents, all right? Other agents include the alpha-2 adrenergic agonists, the desmetomidine and clonidine. But clonidine is not classified here. So we have induction agent, we have sedative or hypnotic agents, and other induction agents, we have the Propofol, Etomidate, Ketamine, pentasodium, all right, and others. We have sedative hypnotic agents like Midazolam, and other agents, desmetomidine. So broadly, this can anesthetic can be classified as such. Okay, so let's look at the pharmacokinetics, all right? Induction of anesthesia with IV agent depends on the amount of the agent that crosses the blood-brain barrier. All right, and the amount that crosses the blood-brain barrier is so dependent on about 4 different factors, which are classified as lipid. All right, so number 1 is the lipid. All right, sorry. So lipid or fat solubility. The higher the lipid solubility of an agent, the faster the induction of anesthesia. All right, the higher ionization. The second factor is ionization. The higher the unionized form, the faster the effect of the drug. Protein binding. Remember that it is the unbound form of the agent that is available to cross the blood-brain barrier to exert its pharmacological effect. So the less protein bound, the faster the onset of action. And this, we're looking at distribution. The rate of metabolism and excretion of the agent affect their effect. So agent with slow metabolism and clearance will lead to accumulation of active metabolites with prolonged duration of action, especially on infusion or repeated dosages. So when we are talking about pharmacokinetics, we're talking about the lipid solubility or the fat solubility, ionization of the agent, the amount of the agent that is bound to plasma protein, and distribution in terms of metabolism and excretion. So remember lipid. Okay. Now, so let's go into the individual IV agent. The first one we're going to look at is the thiopentone. Thiopentone. All right. Remember, look at the diagram. So this is a diagram so that you can get used to it. I'm sure many of us are used to it. So thiopentone is a thiobarbiturate, all right, which was introduced into clinical practice in 1934 as the first IV anesthetic agent. Okay, the summary of the effect is there, but we're going to look at it as we go on. So, mechanism of action of thiopentone. Thiopentone is a thiobarbiturate, like we said. So as a barbiturate, it acts primarily at the GABA receptors, both the alpha and beta sites. And what it does is like prolong receptor opening duration, directly activating the channel at high doses. So it enhances the inhibitory effect of GABA receptors. Secondly, thiopentone, like barbiturate, they depress postsynaptic sensitivity and they impair presynaptic neurotransmitter release, all right, preferentially affecting systems like the reticular activating system, which is involved in awake state. They also have membrane stabilizing effects, which resemble the effect of local anesthetics by reducing sodium and potassium conductance after intracellular ionization. And high doses, high concentrations, barbiturates or thiopentone inhibit glucose oxidation enzymes. They depress calcium-dependent channels and enhance chloride conductance, even in the absence of GABA. All right, this further potentiates the CNS depression that is associated with barbiturate. So there are 4 different mechanisms by which barbiturate produces effect, but primarily is by potentiating or enhancing the inhibitory effect of GABA receptors, all right, prolonging the duration of receptor opening and activates the channels at high doses. So properties, all right, so the thiopentone comes in yellowish powder, which is readily soluble in water. All right, when dissolved in solution, is highly alkaline with a pH of 10.5. And this may lead to skin sloughing if injected in tissues because of its high alkaline nature. and may cause tissue gangrene if injected intraarterially, resulting from arterial spasm. We're going to look at some of these things as we go on. All right? It's unstable in solution, and those should be used within a few days after preparation. I remember those days when we started anesthesia, sometimes you have thiopentone left over kept in the fridge, all right, for subsequent use in the other patients. Or know that it's unstable in solution, so it may dissociate, all right, and the side effect may be lost after a few days. Systemic effects, all right. On the CNS, thiopentone produces anesthesia within one arm brain circulation time, that is within 1 second of injection, travels from the vein to the brain, crossing the blood-brain barrier and inducing anesthesia. On the CNS, it decreases cerebral metabolism, cerebral blood flow, and intracranial pressure. All right, and that's why it is used for neuroprotection. And very, very importantly is that it has anticonvulsant properties. On the respiratory system, thiopentone has a dose-dependent depression respiration with transient apnea. Those of you that have used thiopentone, you will know that after you give your induction dose, the patient becomes apneic transiently. More importantly is that it causes histamine release, and that is why it is contraindicated in asthmatic patients or patients with obstructive airway diseases. On the CVS cardiovascular system, thiopentone depresses the myocardium and causes peripheral vasodilatation, resulting in dose-dependent hypotension. Thiopentone is metabolized at the rate of 10 to 15% per hour, and the metabolites are excreted in the kidney. Remember that recovery for thiopentone administration is merely via redistribution, all right, to the peripheral tissues. So what are the indications and side effects? Thiopentone is used for induction of anesthesia. It is also used for the treatment of status epilepticus, and very, very useful for neuroprotection, especially inducing barbiturate coma. The side effects are also not uncommon. One of them is severe anaphylaxis, which occurs in about 1 in 20,000 patients. Extravasation leads to tissue necrosis, and the prolonged infusion of thiopentone can cause electrolyte imbalance, especially hypokalemia and hyponatremia. Prolonged infusion of thiopentone can increase infection risk, and the presence of sepsis will negate the use of thiopentone as a prolonged infusion. Now, this is a common question they used to ask us. I don't know if they still do, especially those of us going for fellowship and MD exams. All right, so you're asked, you accidentally introduced thiopentone into an artery. So intraarterial injection of thiopentone. So what will be your management? So we're talking about tissue necrosis, all right, following intraarterial injection of thiopentone. All right, it's a serious, although rare complication, but it can happen. And how does tissue necrosis occur following intraarterial injection of thiopentone? The first thing is vasoconstriction and ischemia. This may result from direct irritation of the arterial wall once you get into it, and this we call vasoconstriction, ischemia, all right, and ischemia to the affected tissue. All right, the chemical irritants in thiopentone can also provoke an inflammatory response, all right, which exacerbates ischemia and can contribute to the formation of necrotic tissues. It's a very serious complication because it can lead to loss of arm, all right? So it's important immediately you recognize intraarterial injection, you want to discontinue the injection immediately. And if it's possible, you should aspirate the drugs to reduce the amount that is in the blood. All right. They'll use your vasodilators like nitroglycerin or calcium channel blockers to help dilate the affected artery, hoping to restore blood flow to the tissue. All right. Very common thing you can do is to add cold compress, which reduces local inflammation and swelling, especially in the early stages. Further management, all right, depends on the degree of tissue necrosis. Surgical consultation, especially with the vascular specialist, is crucial to restore blood flow to the affected tissue. All right. Vasodilator, the phentolamine, IV phentolamine, can be administered to reduce the vasoconstriction induced by the medication. And if there is suspicion of thrombosis or embolism, you can use alteplase as a thrombolytic agent. Analgesia is painful, so proper analgesia won't care, especially with opioids, and proper won't care elevation of the affected limb and dressing is important. Although it's a very serious complication, all right, its prognosis depends on the timing of intervention and the severity of the ischemia. All right, early management may result in partial or full recovery, but severe cases may lead to permanent damage or loss of the affected limb. So how do you prevent it? Ensure you avoid intra-arterial injection. All right, and number two, early recognition of accidental injection when it occurs. So this is one of the commonest complications, or one of the serious complications of thiopentone once it's injected into the artery, intra-arterial injection. Don't forget that, like I said, that is contraindicated in asthmatics, all right, because of histamine release. These are some of the things you should remember. All right, these are some of the things that should be on the tips of your fingers when you're using thiopentone. All right, thiopentone can be given as a continuous infusion, especially for neuroprotection, like I mentioned. All right, it's elevated intracranial pressure or a patient with status epilepticus. You want to give a loading dose of 5 to 20 milligram per kg over 1 hour, and then infusion at rate of 3 to 4 milligram per kg per hour. All right. You want to titrate your infusion dose as guided by your biceptral index. All right. Biceptral index spectrum or your continuous EEG pulse suppression. But you should be aware that hypokalemia is one of the commonest complications, side effects of prolonged infusion. But the thing is, you do not want to give potassium to replace potassium, because after stopping the infusion, potassium usually returns to normal. But you only give potassium, especially if there's associated arrhythmias, or if serum potassium drops below 2 millimole per liter. Otherwise, with this continuation of infusion, hypokalemia should resolve. All right. Don't forget that high doses thiopentone is immunosuppressive. All right, and often associated with sepsis, which is one of the reasons why we should stop the infusion. All right. Very importantly, is the causing vasopressin resistant DI. All right. At high doses, you can have high output urine, high urine output, greater than 4 mL per kg per hour. And this may require using desmopressin to treat, all right, usually resistant to, what's it called, vasopressin that is secreted from the posterior hypothalamus. So external or exogenous administration of desmopressin, all right, may be required in this patient. So contraindications, absolute or relative. So patients with allergy to barbiturates, patients with porphyria, patients with constrictive pericarditis because of myocardial depression. Status asthmaticus, actually patient with asthma and patient with severe respiratory compromise. So relative contraindications, it means that you weigh your risk and benefit. Severe cardiac dysfunction or patient is shocked because of hypotension, patient with hepatic dysfunction, renal dysfunction, mesothelioma, Addison's disease, myasthenia gravis, and all that. These are some of the contraindications to thiopentone. Okay. The second IV agent we're going to look at is the methohexitone. It's an oxybarbiturate, methoxybarbiturate, similar to thiopentone sodium, but it is more stable in solution, all right? Unlike thiopentone, it is a white powder, very soluble in water to form a highly alkaline solution of 1% concentration. The dose is lesser than that of thiopentone, which is at 1 milligram per kg IV. All right, being a barbiturate, it potentiates the inhibitory actions of GABA on GABA A receptors, and at high concentrations, all right, it increases the duration of the receptor opening without any effect on the frequency, okay, of the channel. Specifically, methohexitone affects chloride channel, causing it to stay open longer, which leads to influx of chloride ion. And this action itself causes inhibitory pathways to activate in the brain, and this will lead to decreased urinary excitability, inducing anesthesia and sedation. So the basic thing we need to know that it is a barbiturate, so it potentiates the inhibitory actions of GABA, especially on the GABA A receptor, and it also causes the chloride channel ion to open for a longer period of time, causing increased chloride inflows into the cell. All right, so with addition to potentiating GABA effect, the inflows of chloride ion, all right, will cause decreased urinary excitability, which enhances its anesthetic and sedative property. All right, the uses for induction of anesthesia, methohexitone is used for rapid sequence induction, especially in elective procedures. All right, it's ideal for day case surgery because it has a faster recovery compared to thiopentone. All right, methohexitone is the most commonly used barbiturate for procedural sedation for ECT, electroconvulsive therapy, and for short diagnostic or therapeutic procedures like cardioversion, bronchoscopy, and dental procedures. One of its commonly used indication is for neurosurgical purposes, where it causes burst suppression in cases of refractory status epilepticus and can be used for cerebral protection because it reduces cerebral metabolic rate. All right, methohexitone can be a good alternative to other agents like Propofol, Thiopentone, for patients who are allergic to Propofol, Thiopentone, and when you require a rapid recovery, or methohexitone may be what you use. I don't know how many of our centers have methohexitone, how many of us have used it before. All right, some of its properties comes in whitish powder, very soluble in water, has a higher pH than the thiopentone with a pH of 11.1, so strongly alkaline. All right, it produces pain on injection, and it will produce the same effect if it's injected, if it extravasates to the tissue. All right, it's lipid soluble. All right, some of the systemic effect or chemical effect is that it induces hypnosis within 1 hour brain circulation time with a faster recovery. All right, it can precipitate transient apnea, causes vasodilatation, resulting in hypotension. All right, and one of the complications is that it produces epileptiform spikes on EEG, and therefore is contraindicated in patients with seizure epileptic patients. All right, so the next agent we're looking at is Etomidate. You can see the picture on the right side, Etomidate. All right, it's an imidazole compound and it is water soluble. All right, it is prepared as a clear aqueous solution in 35% propylene glycol at a concentration of 2 milligrams per ml. The pH is 8.1 and about 76% of it is bound to plasma protein. All right, the dose is 0.3 milligram per kg to the IV route. How does it work? All right, Etomidate is a carboxylated imidazole. All right, and with its unique property, it provides greater water solubility in acidic solutions and is lipid soluble at physiological pH. Because it's dissolved in propylene glycol, it often causes pain on ingestion, and often this pain can be reduced when you give lidocaine before injecting Etomidate. It has a chiral carbon and exists as two enantiomers with only the R positive isomer being hypnotically active. All right, just like barbiturate, it positively modulates GABA-A receptors, enhancing the inhibitory effect of GABA on the central nervous system. Importantly, it may cause disinhibition of extrapyramidal motor activity, and that is why about in 30 to 60% of cases, Etomidate may induce myoclonus seizures during induction of anesthesia. So if you're using Etomidate, you should be on the lookout for myoclonus seizures, all right, during injection or at induction. And this is due to the inhibition of extrapyramidal motor activity. Systemic or chemical effect, it induces hypnosis or sleep within 1 hour brain circulation time. And it also reduces intraocular intracranial pressure. One of the opportunities, one of the advantages of Etomidate is that it's cardiostable, neither cardioinhibitory or cardiostimulating, so it's cardiostable and does not produce any significant respiratory depression. But it suppresses adrenocortical system, leading to suppression of cortisol synthesis. And this is one of its very significant side effects. It's metabolized in the liver and plasma by hydrolysis, and majority of them are excreted in kidney, with only about 2% being excreted unchanged. So Etomidate is an agent for anesthetic induction because it offers several advantages. One of them is that it has a simple dose regimen, has a fast onset of action, and a short duration of effect. It's rapidly metabolized with only very few excreted unchanged, very low risk of systemic release, and hemodynamic stability on bolus injection. So if you are asked, compare Etomidate and Ketamine as an induction agent, you know what we are looking for, all right? So if you are comparing Etomidate and Thiopentone, all right, you know what we are looking for. So based on some of the side effects of the other drugs, Etomidate comes handy as a useful alternative. Okay, its use in children below 10 has not been, is not recommended because there's insufficient data. And in elderly patients, you want to give lower doses due to declining renal function. And don't forget that in elderly patients, in hypertensive elderly patients, Etomidate may actually induce cardiac depression. So a typical induction dose of 0.2 to 0.3 milligram per kg injected over 30 to 60 seconds will lead to a rapid onset of anesthesia within 1 minute. That's the 1 hour brain circulation time. All right, if you're using, like we do these days, the presence of other narcotics, like opioids or other neuroactive drugs, will need the dose to be reduced. All right, the duration of unconsciousness in the uses is dose dependent. All right, a dose of 0.1 milligram per kg will provide all right, anesthesia in 100 seconds of anesthesia. Complications, excitatory phenomena at induction, cortisol system suppression, nausea and vomiting. It can induce thrombotic event, and because of the propylene glycol that is made, produced in, it can cause pain during injection. All right, so the next one is ketamine, our guy. All right, ketamine is an anesthetic agent with what I call 9 lives. All right, ketamine has come and gone and is coming back. All right, so we're going to, it's a very interesting IV anesthetics. Okay, is a cyclohexanol derivative, all right, of phencyclidine, and it's known to produce the commonly known dissociative anesthesia, all right, and its mechanism of action is antagonism at the NMDA receptors. Ketamine is water soluble. It's presented as a colorless solution. About 12% of it is bound to plasma. All right, and the dose is dependent on the route. IV is 1 to 2 milligram per kg. IM is higher, 5 to 10 milligram per kg. So ketamine has different mechanisms of action. All right, number one is there is a non-competitive NMDA and glutamine receptor antagonist. All right, number two is there is a partial mu-opioid receptor agonist. And this is what accounts for its analgesic properties. All right, ketamine also has antidepressant effect, all right, by increasing brain-derived neurotrophic factor. And this is due its antagonism at the NMDA receptors. All right. Ketamine also interacts with cholinergic, monoaminergic, and opioid system. That's how it modulates analgesia and sedation. One of the things that was going for ketamine is that they process pharyngeal laryngeal reflexes. So even in untrained hands, ketamine was found to be very, very safe, and because it allows for spontaneous respiration, maintaining normal muscle tone, and it helps with cardiovascular respiratory stimulation. For those days, surgeons used to give ketamine on their own, all right, because of its presumed safety profile. But we know that no drug is safe in the hand in an untrained hand, all right? Rapid or high dose administration may cause transient respiratory depression, and this should be taken note of. Systemic effects, ketamine increases cerebral blood flow and intracranial pressure. All right, they induce post-operative emergence delirium. We're going to look at that very closely as we go on. All right, it is cardiostimulatory, causing about 12% increase in blood pressure and heart rate. And that's a lot of times is preferred for patients who are septic or who are hypotensive or hypovolemic. All right, one of the common effects of ketamine is increase in secretions and salivation. And those days, atropine was commonly used, or routinely used as a premedicant, all right, when ketamine is used because of the increase in secretion and salivation. Those days, those of us who trained where we had no anesthetist, all right, they won't give ketamine without first of all giving atropine, all right, and because of these secretions and salivation that it produces. Metabolism takes place in the liver with active metabolites that are excreted in the kidney. All right, so ketamine is one drug that can be administered via very different routes. IV administration will provide a rapid onset with peak plasma levels quickly achieved. IR administration has a high bioavailability, all right, about 93%, with peak plasma levels, varying between 5 to 10 minutes. Ketamine can be used orally, but it has a very low bioavailability, obviously due to the extensive phosphate metabolism in the liver. Intranasally and intrarectally, all right, they offer better bioavailability than the oral route. Ketamine is metabolized by the cytokine, all right, CYP enzymes, all right, and it also undergoes dealkylation, hydrolysation, conjugation, and dehydration. It rapidly crosses the blood-brain barrier, and plasma protein binding ranges between 10 to 50%. All right, 91% of administered ketamine is metabolized and excreted in urine within 5 days. All right, only less than 20% is excreted as a parent drug or a major metabolite with additional elimination through the bile. Common side effects: nausea and vomiting, dizziness, diplopia, drowsiness, dysphoria, and confusion. Emergence phenomenon, all right, occurs in about 6 to 12% of patients. All right, we have allergic reactions, we have anaphylaxis and angioedema. All right, we had a patient recently, or last year, who had suspected anaphylactic reaction to ketamine that was being given during one dressing in the ICU. Unfortunately, we lost the patient. Okay. So it could be severe anaphylaxis, so we should be on the lookout of it. Transient hypertension, bradycardia, left ventricular dysfunction in patients with heart failure, all right? And sometimes it can cause cardiac arrest. Muscular stiffness, tonic-clonic movement resembling seizures can occur due to increased skeletal muscle tone. All right, you can have psychiatric side effects like amnesia, anxiety, confusion. That's why you have emergence phenomena. All right, and it may also cause pain on ingestion, erythema and rash from anaphylactic reactions or sensitivity reaction. All right, neurogenic, like we mentioned as we go on. So contraindications: when should you not use ketamine? Patients with aortic dissection, patient with uncontrolled hypertension, patient with MI, patient with aneurysms due to increased blood pressure, all right? Patients who have hypersensitivity to ketamine, maybe with prior anaphylaxis and edema to ketamine, we should avoid the use of ketamine in this patient. All right, warning, let me just, all right, post-operative emergence delirium. All right, there's a case study we did that was published. An elderly patient who had PED following post-operatively, post-anesthesia. So post-operative emergence delirium is common, especially with ketamine use, and this is due to its antagonistic effect at the NMDA receptor. All right, so blockage of the receptors will interfere with normal brain activity during emergence from anesthesia, precipitating confusion, agitation, and altered consciousness. It may also be due to its increased sympathetic effect, the release of noradrenaline, all right, and dopamine, all right, which will contribute to agitation, anxiety, and preservation of cerebral perfusion, oxygenation, and the presence of stress response may lead to neurocognitive disruptions, especially a patient with pre-existing vulnerability to a delirium. Disruption of the normal sleep patterns, all right, especially the rapid eye movement, all right, can contribute to disorientation, which may lead to post-operative emergence delirium. All right, risk factors common among older patients, patients who have pre-existing cognitive impairment, all right, patients that were given high doses of ketamine, all right, patients that have inadequate pain control, and the use of other concomitant drugs like sedative and analgesic may enhance the likelihood of emergence delirium, especially if high doses of ketamine was used. So how do you manage it? First and foremost, you want to prevent it. So reduce the dose and duration of ketamine, all right? Sedate your patient, especially adequate sedation with other sedatives or hypnotics will help patients who have anxiety or psychiatric disorders. All right, multimodal analgesia will help, all right, so because it also reduces the need for high doses of ketamine. All right, you must recover your patient in a calm and quiet environment to reduce the occurrence or incidence of post-operative emergence delirium. All right, so when it occurs, what do? You reassure and orientate the patient. Patient waking up from anesthesia may be agitated, so you explain, we just finished surgery, you are in the recovery room, surgery went well. Always is a good practice to allow relatives or familiar voices, all right, to be around the patient as they are waking from anesthesia. In severe cases, you may want to prescribe haloperidol or respiridol, all right, as the case may be. Monitor the patient for signs of post-operative emergence delirium so that you can intervene fast. All right, Propofol. All right, the meek of anesthesia. All right. So Propofol is 2,6-diisopropylphenol. All right. It is soluble in water and is formulated as an oil in water emulsion containing soybean oil, glycerol, and lecithin, derived from egg yolk. Appears milky white, and slightly viscous, with a pH of around approximately 7. Standard concentration is 1% at this 10 milligram per ml, although we have some formulations that come as 22% formulation. Contains preservatives, all right, and some of these things help to reduce bacterial growth. Know that sterile technique is crucial, all right? And when you open your vial, you should use it within 12 hours to prevent contamination. How does it work? It has a positive allosteric modulator of the GABA-A receptor, all right? Just like the barbiturate increases GABA binding, prolonged chloride channel opening, which lead to neuronal hyperpolarization and inhibition. Note also that it reduces glutamine-mediated excitatory transmission, all right, by acting on the NMDA receptors. All right, this contributes to its hypnotic and anti-epileptic properties. All right, so it's presented as a white oil in water emulsion containing soybeans oil and purified egg phosphate. It is acetonic with a neutral pH, like we mentioned. It's almost completely bound to plasma, about 98%. The dose ranges between 2 to 2.5 milligrams per kg. Systemic effect or chemical properties: reduces cerebral blood flow, causes a reduction in ICP, all right, may be associated with risk of seizure. Cardiovascular system, causes vasodilatation with a drop in pH, blood pressure and cardiac output. And sometimes you may have a slight rise in heart rate as a compensatory mechanism. Okay, induction of propofol is often associated with apnea, all right, especially in theater. We will be careful of it, all right, so that you have proper adequate pre-oxygenation before administering induction doses of propofol. We've had patients go into respiratory arrest, especially with high doses. Patients requiring more than 2.5 milligrams per kg may actually become apneic, all right, following induction of anesthesia and propofol. All right, it's metabolized to inactive products, which are excreted in the urine. Okay, most of the time, the common route of administration is intravenous with a rapid onset of action that is dose dependent, and the duration of action is less than 1 minute. All right, prolonged or repeated administration will cause accumulation in peripheral tissues, and this will cause an increase in duration of action. All right, it undergoes both hepatic and extrahepatic clearance, all right, and most of which is via the kidney. Propofol is also biphasic. Its initial half-life, biphasic in terms of half-life, its initial half-life is around 40 minutes, and the terminal half-life can be as high as 4 to 7 hours. Excretion primarily is through the kidney. All right, clinical uses: induction of anesthesia in patients who are more than 3 years old, all right, and maintenance of anesthesia, sedation during monitored anesthesia care for patients undergoing procedures. And for mechanically ventilated patients in the ICU, it can be used for sedation. The problem with this is that it requires large amounts of ampoules of propofol to be able to adequately sedate your patient. All right, and that's why I don't commonly use it. We use opioid and benzodiazepine-based sedation protocol in our ICU. All right, but where sometimes, all right, propofol for sedation, continuous infusion may be advocated for. All right, complications of cardiovascular, respiratory depression, and they can cause pain on injection, don't forget that. So my mnemonics for propofol is that the 5 P's of propofol is a phenol derivative, contains purified air phosphate, almost completely protein bound, about 98%. It has a neutral pH and produces pain on injection. So if you just remember the 5 P's of propofol, you are good to go. Now, one of the very rare but life-threatening complication of prolonged infusion of propofol is what we know as the propofol infusion syndrome, the PRIS. All right, it manifests with metabolic acidosis, hyperkalemia, hyperlipidemia, rhabdomyolysis, which can also precipitate acute kidney failure. All right, cardiac failure may result, which will lead to death. It has a very high mortality, about 33%, and it worsens with delayed recognition. How does propofol infusion syndrome develop? It's thought to be due to mitochondrial dysfunction and impaired electrotransport. All right, it's more common in pediatric and young adult patients, or those patients require long-term sedation, especially patients who are mechanically ventilated. All right, so the diagnosis of PRIS is a diagnosis of exclusion. All right, and once it's suspected, especially in susceptible patients, you want to immediately discontinue the drug and initiate supportive care by correcting the metabolic abnormalities and manage multi-organ failure. So prevention is better than cure. You want to limit dose and duration. All right, so you want to avoid giving high dose infusion of more than 4 milligrams per kg per hour, and reduce the duration to less than 48 hours and below. All right, you want to monitor metabolic and organ function by frequent ABG. So a patient who is on propofol continuous infusion in ICU should have regular ABG monitoring. All right, check your creatinine kinase levels for rhabdomyolysis. All right, once you suspect, sometimes PRIS can mimic severe sepsis. All right, so that's why you want to look at your triglycerides level. You want to check your CK levels if it's elevated, and other renal cardiac function. This will help you to differentiate it from severe sepsis. All right. So you want to consider alternative sedation strategies like we do in our ICU, or you want to combine propofol with other hypnotics to reduce the infusion rate. Early recognition intervention, all right, is crucial. All right, as you suspect it, you just swing into action. All right, let's look at this case-based scenario that I brought in here. A 22-year-old male patient with severe TBI is being mechanically ventilated, and for sedation is being on propofol infusion at dose of requiring a dose of 5 milligrams per kg per hour for 3 days. All right. All right, the patient develops refractory bradycardia, metabolic acidosis, and hyperkalemia. All right, so what will be your diagnosis here? This is a case-based scenario. What will be your diagnosis, and how will you manage this patient? Because of time, I would have called somebody, but because of our time, all right, so this most likely going to be a propofol infusion syndrome. From the history, all right, this patient is having high, all right, doses of propofol, more than 4 milligrams per kg per hour for more than 48 hours. All right. So it has metabolic acidosis and hyperkalemia. So we want to take this case as a case of Propofol infusion syndrome. All right. So you manage, you stop Propofol immediately. All right. You want to do organ support and also try to confirm with your CK levels and other like triglyceride levels. So that will confirm it, and you initiate multi-organ support for your patient. Midazolam, our time is fast spent, man. Let me see how many. Midazolam. Oh my God. Okay, let's see. Let's see. Oh. All right, Midazolam. You know Midazolam, that is here is a water-soluble benzodiazepine with anxiolytic, amnesic, sedative, and most relaxation properties. All right, this actually will give you a complete anesthesia. It's lipid soluble, crosses the blood-brain barrier. Half-life is about 2 hours. It's used for rapid induction of anesthesia. All right. Also used to manage acute seizure and status epilepticus. Boca and intranasal administration makes it useful, especially in pediatric seizure control. It can also be used for maintenance of anesthesia, all right, and for sedation in local regional anesthesia and mechanical ventilation. All right, its mechanism of action is indirect. It involves both GABA accumulation and binding to benzodiazepine receptors, increasing chloride channel opening frequency. All right. Now, this is different if you look at the effect on GABA receptors and chloride channel. Let me quickly state it here. All right. For barbiturates and other agents that potentiate GABA effect, all right, they increase duration of opening of the channels, while for midazolam, they increase the frequency of opening. I hope you understand that. For barbiturates and others, it is the duration of opening of the channels, chloride channels, while for midazolam is increasing the frequency of the chloride channel opening. All right, this leads to membrane hyperpolarization and neuronal inhibition. Okay, it also has some glycine receptors, and this is how it produces its muscle relaxation effect. All right, its pharmacokinetics are influenced by age, hepatic, and renal function. It is metabolized by the cytochrome enzyme CYP450. All right, and undergoes glucuronide conjugation into active metabolite, the alpha-1 hydroxy midazolam, which contributes to 10% of its therapeutic effect. Okay, let me see. I can't finish this today. I think we should stop here. All right, this the hour mark, and I will send the slide to us so that we can read the other ones. All right, I don't want to go more than 1 hour. So, ladies and gentlemen, colleagues, let's stop here. Any questions, any contribution?